Hello and welcome to this Satellite, HIV Epidemiology in Southern Africa, Critical Questions and New Methods. My name is James Hargreaves and I direct the MESH Consortium funded by the Bill and Melinda Gates Foundation, who are co-hosting this satellite with the HIV Modelling Consortium. Our satellite's in two parts. Today, myself, Andrew Phillips and Edinah Mudimu from University of South Africa will talk about strengthening routine HIV data and enhancing the use of models to inform program design. We will be followed by our colleague Mina Hosseinipour and her colleagues from the Malawi Ministry of Health to talk about reshaping HIV monitoring and measurement through new technologies. Our live satellite on the 6th of July will be chaired by Michelle Morrison, Lee Johnson from UCT, Francis Cowan from SESHA, and Dr. Owen Mukurungi will discuss a range of issues to do with strengthening the use of routine data for HIV monitoring and surveillance, followed by a panel discussion. So how do we strengthen routine HIV data and enhance the use of models to inform program design? Let me introduce the MESH Consortium. The mission of MESH is to improve the measurement and surveillance of HIV in Southern Africa in order to inform prevention and treatment monitoring and to transform the insights we have from data into tracking HIV incidence decline. We have three objectives: to characterize the locations, populations and individuals at greatest HIV risk to inform prevention programs, to improve measurement and estimation of HIV incidence through the use of routine HIV testing platform data, and to better understand HIV risk and clinical outcomes through the analysis of individual level data collected from people living with HIV. MESH thinks of HIV routine data in these ways. We consider both data collected through service delivery platforms and surveys that are driven by programs to answer outstanding questions. We consider data from HIV prevention, testing and treatment programs. In the slide, you can see a range of examples of these types of data, from data from PrEP delivery, testing data collected in the home or through self-testing programs, and data collected through hospitals, clinics, pharmacies, and surveys such as with clients who are lost to follow-up. All of these data comprise the HIV data of interest to MESH to improve HIV measurement and surveillance. Our focus is in three Southern African countries: South Africa, Zimbabwe, and Malawi. In Malawi, we work with the University of North Carolina, Project Malawi. In Zimbabwe, with the Center for Sexual Health and HIV/AIDS Research, and in South Africa, with the University of Cape Town. Each of these academic partners has strong links with the Ministry of Health, who are central to our mission and to our work in country, being part of our advisory and review panels to check on our work. MESH's second mission is to foster national, regional, and global communities of practice on the optimal use of routine data for HIV measurement and surveillance. We run satellites and symposiums in order to bring people and expertise together to discuss these issues. Through a website, we provide tools and briefings on these issues, including videos and a range of infographics and other useful information for those concerned with the use of routine HIV data to improve HIV surveillance. Let me end this brief introduction to MESH by giving a couple of examples of recent rapid use of routine data to answer critical questions about the intersection between HIV and COVID-19. We will address the two questions on the slide. Firstly, of critical importance is to understand whether people living with HIV are at greater risk of COVID-19 mortality. In South Africa, led by the Western Cape Provincial Department of Health through its partnership with UCT and MESH, undertaken by Mary-Ann Davies and Andrew Bull, we use data from the routine data system to address this question. In the Western Cape, data is brought together in a health information exchange or data center from a range of disease monitoring, laboratory and clinical platforms. These data are linked together through a unique identifier and are used for a range of applications, including to support clinical care. But in this case, we will talk about epidemiological analyses of the data. The database brings together linked data on all public sector patients, around 3.5 million active patients over 20 years old who had not died before the 1st of March 2020. Comorbidities in these individuals can be inferred from the data system through their interaction with labs, drugs, and encounters with health services. And these data we use to look at factors associated with COVID-19 death in all public sector patients. Here are the findings. There were just over 500 deaths in the system amongst these 3.5 million patients. Men those who were older, and those with comorbidity non-communicable disease were all at greater risk of COVID-19 death. In addition, those with both previous and current tuberculosis had a higher risk of death, as did those who are HIV positive, regardless of their treatment status reflected in the routine data. The group calculated standardized mortality ratios to compare the actual with the expected number of COVID-19 deaths in people living with HIV. After adjustment for age and sex, the standardized mortality ratio for the increase in COVID-19 death in people with versus without HIV in the Western Cape was 2.39. This means that across the public and private sector, around 8% of COVID-19 deaths may be due to HIV. These findings warrant further investigation in a range of ways, but they show the power of these routine data systems to rapidly answer questions of critical importance. A second important area is whether lockdown associated with the COVID-19 pandemic has influenced the access to health services for a range of groups. We investigated this among female sex workers in Zimbabwe, where the prevalence of HIV is over 50% and the rate of new infections exceptionally high. Because of this, optimizing uptake and engagement with clinical services for female sex worker programs is critical. The Centre for Sexual Health and HIV/AIDS Research provides such services through 57 clinics across Zimbabwe and has reached over 90,000 women over the past 10 years. We used an interrupted time series approach to look at the effects on program engagement of the imposition of lockdown in March 2020. This slide shows the effect on HIV tests being delivered by the program. This slide shows the impact in March of reduced numbers of clinic visits associated with lockdown. And this final graph shows the association with the number of HIV positive tests delivered by the program over this period. In addition, we rapidly brought together an additional module of questions to improve the program by asking about the effects of COVID-19 lockdown on the sex work in Zimbabwe. Most women reported that fear of COVID-19 had affected their business. The mean number of clients that they reported within the last month reduced compared with recent respondent-driven sampling surveys, and almost all women reported that the number of clients was lower than normal. These complex interactions between epidemiological risk, access to health services, and socioeconomic and livelihood opportunities are of critical importance to investigate further. The routine data help identify these questions. Our colleagues from Malawi Mesh will be speaking later in the session, and I shall now hand over to Andrew Phillips and Edinah Mudimu.
Thank you, James. I'm Andrew Phillips from the HIV Modelling Consortium, and I'm just going to give a brief update. So the aim of the Modelling Consortium is to facilitate modelling to inform development of strategies and interventions to reduce HIV incidence and mortality in sub-Saharan Africa. And we aim to do this by enabling collaborations and mutual support between modellers, to enable engagement between modelers and epidemiologists, implementation researchers and policy stakeholders, and to enable sharing of data and expertise. I'll just tell you briefly about some of the new modelling collaborations that we have starting up, or in the case of the first one, already completed. And Edinah Mudimu from University of South Africa will talk about this after me. So I won't dwell on the first one. All of these are collaborations involving different modelling groups contributing to looking at similar questions so that we can gain as much information as we can and we can learn from each other. So the second one down here is to look at the risks and benefits of restarting HIV prevention activities in the midst of ongoing COVID-19 epidemics. This is going to be led by John Stover from Edinah Health, and it leads on from the first project that Edna is going to be talking about. Another project is on informing VMMC provision in districts and countries within sub-Saharan Africa, and that's going to be led by Loveleen Bansi Mafaru. And lastly, on this slide, a project on effectiveness, cost effectiveness, and respiratory infection control benefits of expanding community delivery and task shifting for HIV/AIDS services. And that's going to be led by Anna Berstein from NYU. And the respiratory infection control benefits relate to tuberculosis and influenza and other respiratory infections, as well as COVID-19. To continue with these projects, there's a project to be led by Lee Johnson from UCT, who's speaking later in this symposium, on modelling the effects of structural interventions, social enablers on HIV incidence and mortality in sub-Saharan African countries. Then there's a project that's so far only one modelling group involved in, which is ours, on modelling to inform potential changes to the WHO viral load ART monitoring algorithm. And then lastly, for now, there's a kind of large overarching collaboration, which we're calling MIPSA, which is modelling to inform HIV programs in sub-Saharan Africa. And this is really something that we envisage as being led from colleagues in ministries of health and NACs within countries in the region, along with us as HIV modelers and economists. And the aim is to pool insights from multiple models with close engagement from stakeholders at all levels in order to inform the future design of country HIV programs, with specific example countries being Malawi, Zimbabwe and South Africa, but we hope to be able to be saying things which are relevant to other countries as well, so they will be included. If anyone who's watching this, for all of the projects that are just starting up, we're keen to bring in new collaborators who wish to contribute, so please contact me on that email address if you feel like you can contribute. And more broadly, anyone who's interested can become an affiliate of the consortium. Just get in contact with me, and that would put you in the position where you'll be hearing about what's going on and kept up to date with it. If that's all you want to know, you don't need to provide any feedback, but you can, propose new projects which would be considered. Now, I'm grateful to James and the MESH team for inviting us to be part of this symposium, and we value the opportunity to work with MESH and intend to build on that as much as possible. We share the same underlying aim with MESH, which is to support development of strategies and interventions to reduce HIV incidence. And so we'll contribute to each other's projects to the extent possible in order to jointly support countries in achieving that aim. So I'm just going to give you a sense of the large number of affiliates and collaborators that we're linked up with. I'm obviously not going to name them all, but on this slide and the following slide is an incomplete list of many of the colleagues that are involved as collaborators, and most of which are affiliates. So now, as I mentioned, I'd just like to now introduce Edna Mudimu, who's going to talk about this collaboration that we've just undertaken to look at the potential effects of disruption to HIV programs in sub-Saharan Africa caused by COVID-19, results from multiple mathematical models. Edna, please, thank you.
Thank you, Andrew. Thank you for introducing me. I will present results from 5 independent HIV models to estimate the magnitude of effects on numbers of HIV-related deaths and new infections resulting from disruption of HIV health services. This work is under review with the Lancet HIV. I shall begin with a brief background to this study. Disruption to delivery of healthcare services in sub-Saharan Africa settings caused by COVID-19 non-pharmaceutical interventions could lead to adverse consequences for the health of people living with HIV and people at risk of acquiring HIV. Negative effects of the COVID-19 pandemic on access to health services are emerging in the region, as indicated by the first speaker. For example, a survey in South Africa found that 13% of people did not have access to their chronic medication during lockdown. We explored these potential effects using existing mathematical models of HIV epidemiology and intervention programs in sub-Saharan Africa. 5 well-described models of HIV epidemic, namely GOALS, Optima HIV, HIV synthesis, Imperial College London model, and eMod were used in this study. 2 out of the 5 models are individual-based models, and the other 3 are compartmental models. The models have different features, some of which are listed in this slide. Important to note are different model assumptions relating to effects of antiretroviral therapy interruption. The models handle this in various ways, but most attempt to reflect an assumption that immune recovery during ART would be quite rapidly lost after interruption of treatment. All models simulate disruptions caused by COVID-19 that last for 3 or 6 months, from 1 April 2020 at 20%, 50%, and 100% service interruption levels to persons who would otherwise benefited from a given HIV health service program. The diagram on your left shows the scenarios investigated in this study. The potential disruption to programs are broadly grouped as prevention programs, which include service interruption of VMMC and condom availability, HIV testing, and treatment and care, which includes service interruption of ART initiation, ART retention, prevention of mother-to-child transmission, viral load testing, enhanced adherence counseling, and regimen switches. The baseline scenario is one in which no COVID-19 HIV health service disruptions occurs. For each disruption scenario, we predict the increase in HIV mortality and HIV incidence over a 1-year period or annually over 5 years relative to the annual number of such deaths and incidents in which no COVID-19 health disruptions occur. Healthcare service use is assumed to return to pre-disruption period levels at the end of the disruption period. Simulations were run without and with background decrease in risk sexual behavior during the temporary interruption of HIV health services. A 10% reduction in casual and commercial sexual conduct was assumed for the duration of the health service interruption period. I'll present some of the results obtained. The graph on your right shows the average relative change in HIV mortality in 1 year resulting from a 6-month disruption of HIV health services for 50% of the population, assuming no change in sexual behavior. Generally, interruption of health services for people living with HIV are associated with increases in mortality risk. Most notably is the disruption to ART supply to people on treatment. 6 months of such interruption to 50% of people is expected to lead to a 1.63-fold increase in HIV-related deaths in sub-Saharan Africa over a 1-year period compared to the case with no disruption. In absolute numbers, the predicted excess number of HIV deaths across models is approximately 296, ranging between 229 and 420 excess HIV deaths. Interruption of prevention of mother-to-child transmission services could lead to significant increases in the number of new child infections. According to GOAL's model, an estimated increase of 81% in Malawi, 41% in Mozambique, 70% in Uganda, and 53% in Zimbabwe is expected. The graph on this slide presents results for the average relative change in HIV incidence in 1 year resulting from 6 months disruption of HIV health services for 50% of the population, also assuming no change in sexual behavior. A general increase in new infections is observed in most scenarios, except for interruption of VMMC services, which has the lowest increase in new HIV infections. Interruption of condom programs for 50% of the people has the potential of increasing new infections by up to 19%. With reduction in risk sexual behavior, new infections decrease by a net effect of 4% in 1 year. All models predict an increase in HIV incidence with ART interruption. eMod model predicts that this would be a particularly large effect, perhaps due to the transmission during acute HIV infection, causing a synchronous wave of secondary spread, which might be more pronounced in a network model. While there is some uncertainty around the magnitude of the impact that program disruptions could have on HIV epidemic outcomes, there is a consensus across the 5 models that interruption of antiretroviral treatment represents the greatest threat to HIV outcomes. All models predict that ART interruption in the absence of change in sexual behavior will lead to the largest increase in HIV incidence and the largest predicted excess number of HIV deaths. Interruption to condom supplies could make populations more vulnerable and results in an increase in HIV incidence, although physical distancing measures could lead to reductions in risk sexual behavior. Important limitation to note from this study is that we do not model any interaction between HIV and COVID-19 infection. That is, people with HIV are not assumed to be more likely to acquire or die from COVID-19. It is also important to note that there are several models that address excess mortality from disruption of services for malaria, HIV, and TB, and other communicable diseases. All these models point to similar levels of excess death. Results from this modeling exercise show that HIV healthcare provision of all types should be prioritized for maintenance, with modifications if needed during the period of threat from COVID-19. Proposed modifications include multi-month drug dispensing for ART and extra emergency provision of supplies to be able to safely provide existing levels of health care at the same time responding to COVID-19 pandemic. The analysis done in this study heavily depends on data obtained from public health surveillance. Public health surveillance on disruption of health services for HIV and other diseases in most countries, including countries in sub-Saharan Africa, is ongoing. International organizations like UNICEF, WHO, and PEPFAR have implemented tools to monitor health service disruptions through reports on service delivery statistics from public and private health units in different countries. This surveillance helps countries to monitor and evaluate emerging patterns and trends in health service disruptions. Good surveillance data is needed to inform mathematical models that can be used to detect possible changes in disease epidemiology caused by health service disruptions. This is critical in planning, implementation, and evaluation of public health and facilitates the process of finding active solutions in a timely manner. In conclusion, it should be noted that any disruptions to healthcare provision will have a negative health impact on affected individuals, but it is helpful to have a clear appraisal of the aspects of existing care provision that are most critical to preserve. This is possible if collaboration among practitioners, researchers, nations, and international organizations is promoted to address the global needs of public health. Thank you.
Hi, I'm Mina Hosseinipour, and I will be moderating today's IAS virtual session entitled Reshaping HIV Monitoring and Measurement Through New Technologies. This is one component of the MESH Consortium activities for IAS, and we are excited to be able to present some promising technology and data use platforms that may improve HIV program monitoring. To summarize our plan for the day, I will discuss past and current status of HIV program monitoring. Mr. Kumwenda, a PhD student at the University of Malawi, will discuss biometrics for identification. And Dr. Likaka, the director of the Quality Management Program and Digital Health Platform of the Ministry of Health, will discuss the Digital Health Department at the Ministry of Health and Population. Then we hope to discuss challenges in incorporating novel technologies into the HIV program. Since the inception of the HIV program, the Department of HIV and AIDS in the Ministry of Health has provided systematic, consistent reporting across all facilities. This has allowed the team to accurately follow trends over time. Their website allows interaction and access to the most relevant documents and reports that are highlighted here. The HIV program reporting includes a wide range of reports, including HIV testing, ART initiation, early infant diagnosis, blood safety, pre-exposure prophylaxis, PMTCT, TB, HIV, and sexually transmitted infections. It is a quarterly system that includes site supervision teams that visit the sites to confirm the data. It is primarily facility level data that is collected and consolidated, and patients initiating therapy are assigned to a cohort over time so that their retention can be monitored. Designed to be a paper-based registration initially, electronic medical records have increased over time. This does have patient level data, but the program level reports still remain facility based. Here we see an example of the outputs of the program. In this graph, we see the number of HIV testing done each quarter over the last decade. We see that testing has increased over time, but the yield of new positives has decreased, although the absolute number of new cases is relatively stable. And here we see the number of new initiations on ART over time. Initially, this increased with the expansion of the ART program to new sites, and now it has somewhat plateaued in terms of new numbers, as highlighted in yellow with the test and treat era. In blue, we also see a feature of transfers into each facility. And this represents a sizable proportion of attendees at a given facility. It highlights the mobility of individuals that are in the ART program in Malawi. This mobility presents challenges to HIV programming. Specifically, ART initiation rates can be skewed by defaulters returning to care and registering as new initiators. Likewise, silent transfers, these are individuals on antiretrovirals at one clinic who present to a new clinic and pose as a new initiator. With HIV testing, we see repeat testers, self-reporting as being first-time testers, and the same defaulters and silent transfers that I've mentioned also report to be new HIV testers. Retention metrics are also potentially decreased by transfers between the clinics that are not accurately documented. Importantly, this program data that I've just described is used to generate our spectrum estimates for new infections, pictured here on the left, estimated to be 37,000 new infections in 2019. And on the right, we see Malawi's positive progress toward 90-90-90 for treatment. And we expect that 95-95-95 will continue to be a goal. So the accurate primary data is critical for understanding the epidemic as we move forward. What are our strategies for data improvement? Essentially, the electronic data systems need to talk to each other across different clinics in the country. We need patient-level data, and that requires unique identifiers that may be national ID, ART ID, or novel identifiers that we will discuss in just a moment. And we need to recognize that we have to be able to apply these to new initiatives as they begin. And this includes pre-exposure prophylaxis program and a new recency testing to identify new infections. So now I'm going to hand off to Mr. Kumwenda, who's going to discuss biometrics at UNC Project Malawi.
I'm delighted to present biometric experience at UNC Project. As already presented by Professor Mina, there is need for countries to have strong unique identifiers for patients in order to improve data quality of care across the continuum of care. So traditionally, health systems have relied on participants presenting their identifiers and history probing. So if a participant deliberately lies about their identity and their clinical history, it compromises the quality of care and is costly for the health system. Biometrics is a way forward because it identifies the patient based on their traits which are unique to each individual. Different types of biometrics are used, like fingerprint, voice, face recognition, and DNA matching. The common and developed biometric technology is fingerprint, which have been used in national projects like voter registration. I will now present 3 projects that we are using fingerprint biometrics at UNC Project. So we have got the Connect study, which is using biometrics to improve retention and re-engagement in HIV care across clinics. The Connect study explores, it is exploring using biometrics scanning to monitor engagement in HIV care across HIV clinics in the Longo district among women enrolled in option B+, whereby we are evaluating how biometrics fingerprint scanning compares to the current HIV monitoring system, recording HIV visits, identifying transfers between clinics, identifying women who are lost to follow-up. So this study has been conducted in, this study has been conducted in 3 phases. That is the formative, pilot, and the scale-up. At the moment, we have completed the formative phase, the pilots and pilot testing. We are currently conducting the scale-up phase. So for the formative finding, where we were, the results indicated that biometric fingerprint scanning is a preferred strategy among both women and healthcare workers compared to mobile-based strategies. That is the text messaging and SIM card scanning. The reason why the preference, there was less preference with mobile-based strategies was low phone ownership, illiteracy concerns, frequency setting of the mobile phones, and the cost of charging of mobile phones. Whilst the facilitators for the biometric was ability to reliably and uniquely identify women, although there was concern related to additional financial resources if we were to implement this particular strategy, including the training and additional staff. For the pilot study, where we assessed feasibility and acceptability, it was found that biometric fingerprint scanning is feasible and acceptable method to identify women in option B+ and monitoring visits. No concerns were raised related to privacy and confidentiality for biometric data were reported among study participants. Biometric fingerprint scanning captured 80% of the expected visits compared to the 51% in the current EMR system that used to monitor visits. The missed visits were missed in December and early January. This is when the government clinics were closed and staff were on holiday, the study staff were on holiday. And at the end of the study period, staff may have focused on conducting exit visits, thus missing some of the visits that were expected. Another area was whereby we used the biometric system in HVTN and HPTN prevention studies. So we have got 2 prevention studies, that is HPTN 084 and HVTN 705, who are recruiting a similar population from the same catchment area, but different sites that are closed in Lilongwe, Malawi. So implementing the biometrics, the purpose was to avoid enrollment, with which we wanted to eliminate potential safety concerns of using two products at the same time, prevent any compromise to research integrity or interpretation, prevent research unblinding in the case of vaccine-induced positivity. All participants enrolled in this study has accepted use of biometrics and no issues have been raised by the study participants. We also implemented the biometric system in the STI clinic. So UNC Project provide STI management and treatment services to patients presenting to the STI clinic at Bwaino. These participants, usually they do lie about their identities. Sometimes we need more things. So UNC Project implemented an electronic system and a biometric system at the STI clinic to identify the visits with an aim of enhancing data quality and quality of care. The majority of participants accepted, and most failures were related to scanning were related to the learning curve of the staff to the system. So through the three areas that we implemented, we used 3 different systems of biometrics. Like for Connect study, we used SimPrint. HPTN and HPTN, we used Morphos. And STI clinic, we used M2 SYS. So for the Connect study, the study data collection system was integrated with biometric system. And for the online and offline, with online, it means it requires internet connectivity. Offline doesn't require the internet connectivity. So some of the things that we need to consider are the cost implication whenever we want to implement the biometric system, and how we are going to integrate the biometric system within the existing system, that is the electronic medical systems. In addition, we can also consider it as a supplement. We need to still have the existing identifiers, because not all users can be involved in using the fingerprint biometric system, for example, people with disability, and also to consider about the physical changes over time. And the type of fingerprint biometric system we also need to consider because of the algorithm based on the sensitivity and specificity of matching of the fingerprint itself. And then adherence to standard of procedures. Use of long finger renders system root. Thank you. Now I'll pass it to Dr. Likaka.
All right, so I will just sum up by giving a brief background to link up on the need of technology to enhance improvement. So the Ministry of Health has set up Quality Management Department, which has got 4 divisions. This process started as early as 2016, knowing that the improvements that have been made with HIV care, as well as technologies coming in, there is need to improve on setting up standards, also working on what works and what doesn't work, making improvements based on the experiences that we've had managing HIV. So we have quality improvement, and we have a division responsible for quality planning. We have a division that is responsible for measurements, that's quality assurance or quality control, and digital health. So digital health essentially is looking at using technologies to improve service delivery in Malawi. So the 3 examples that have been given by the various projects that my colleagues have highlighted clearly shows you how technology can be used to enhance delivery. Also linked to digital health is the DHIS2, which is popular in Malawi. All data is fed into the DHIS2. Efforts have been made to ensure that there is real-time reporting from facilities. We've launched a health situation room, which also is able to capture and project data for HIV, maternal and newborn, as well as other disease programs in Malawi. Our vision is to see real-time reporting for all data sets at programmatic level. Let me stop here and open up for discussion. Thank you.
So, Dr. Likaka, would you like to comment on how the biometrics would integrate with the DHIS2?
Yeah, so essentially there are two levels of data management. First of all, is the patient level data. You know, there's all about demographics, about what happens, what the clinician writes. And there is the other level, that's disaggregated data. That's the data normally that goes into DHIS2. So in Malawi, we are working on unique identification. No single method is ideal. As I'm talking now, we have a national ID, which is being explored. But for security reasons, we want to also match the national ID with the biometrics. And the work that my colleague has presented fits in quite well in that aspect. So biometrics will be used as one of the methods for identifying people when seeking services. I think this also, you need to be aware that majority of our patients are illiterate, and at times someone can forget because there's been a call when we come with a unique identification that there is a possibility of leaving others behind. So biometrics will be very ideal not to leave anyone behind when we introduce technology.
Would you like to comment on how network connectivity and infrastructure at the health facilities might play into implementation?
Yeah, as we're talking, as of 2016, 34% of our facilities had network connectivity. But I'm pleased to inform you that now over 85% of the facilities are connected. We've got a major program on setting up digital infrastructure in Malawi, and that includes connectivity as well as hardware and software development and installation in all the sites. Connectivity really can be challenging and can mess up things. We are coming from a background where people are used to paper, and any setback with connectivity becomes a challenge. And the majority of our facilities are in rural areas where connectivity is, we are struggling to push connectivity or bring some innovations to make sure that we reach those areas. So yeah, we can't talk about technology and even all the use of modern biometric measures without connectivity. This will be a paramount issue.
All right, thank you. I'd like to thank our sponsors and the funders of the different research projects that were presented, and the Bill and Melinda Gates Foundation that fund the MESH consortium. Thank you for joining us for this occasion.
Thank you.